Please welcome Professor Senay Karadag Arli, who's going to share with us nurse-led approaches to promote cancer prevention in individuals with intellectual and developmental disabilities.
Okay, thanks for your invitation. Sadly. By the way, I will introduce myself. I am Senay Karadag Arli. I am working as a professor at Ondokuz Mayıs University in Turkey. My major is surgical nursing. And no, nurse-led approach.
Okay, perfect.
Firstly, I want to thanks to your kind invitation. And also, I am very proud of being here with you. I will present a presentation that is called that Nurse-Led Approach to Promote Cancer Prevention in Individuals with Intellectual and Developmental Disabilities. We will wait.
Which one?
Sorry.
This one.
Yes.
Perfect.
Yes. Okay.
Perfect.
Thank you so much. And you'll see the title. When we look at the background, you'll see that individuals with intellectual and developmental disabilities, IDD, face significant health inequities, including reduced access to cancer prevention and screening services. Also, we will talk about that. Systemic barriers, low health literacy, and limited awareness of cancer risk factors contribute to delayed detection and poor outcomes. Nurses, as primary healthcare providers, in continuous contact with this population. So, they are uniquely positioned to lead interventions that promote cancer prevention and health equity. This review aims to synthesize current evidence on nurse-led strategies supporting cancer prevention among individuals with IDD. When we look at the methods, you can see that this is a narrative review was conducted using recent international literature focusing on cancer prevention in adults with IDD. Also, key studies examining awareness of cancer risk factors, symptom recognition, caregiver perspectives, and healthcare disparities were included to highlight implications for nursing practice and leadership. And the results, you also see that individuals with IDD have lower awareness of cancer risk and symptoms, while caregivers' knowledge strongly influences preventive behaviors. Also, studies show that persistent inequalities in access to cancer prevention and nurses play a key role through education, advocacy, and individualized care. And also, caregiver-focused nursing interventions improve participation in preventive services and strengthen communication between patients, families, and healthcare providers. What are the implications for nursing practice? When we look at this side, from this side, we need for specialized training for nursing. And also, we should integrate intellectual and developmental disabilities content into undergraduate and postgraduate nursing curricula to build foundational competencies. We need integration of IDD-friendly screening programs. Also, we need policy development for equitable cancer prevention. And we need expansion of community nursing roles. In the conclusion, you see that nurse-led approaches are essential in reducing cancer disparities in IDD. Additionally, multidisciplinary and inclusive strategies improve outcomes. There is a gap in this area. You will see that. And future research is needed on intervention effectives. And finally, we need randomized and longitudinal studies. This is my references and my contact details. Thank you for listening to me.
Thank you for presenting to us. It is repeated for the second day how much we need training and how much we need to develop our discussions globally. The next presenter is Dr. Kate Sykes. I'm looking for you. There you are. Kate is going to share in more detail now the review of reviews we are working on. You've started yesterday, just a tiny bit, and now please take the floor and introduce us to the more detail.
Thank you. There we go. So, hi everybody. What have I done? Grand, thank you. So, hi everyone, me again. I'm Kate Sykes, I'm Working Group 3 leader for the Cooper project, and I'm here today to talk to you all about the systematic review of reviews. Some people call it an umbrella review that we are doing as part of WG3, and lots of other members of Cupid are involved in this across Working Groups 1, 2 and 4 as well. So, as we've all kind of been made aware over the past few days, and the reason why Cupid exists is that people with an intellectual disability are more likely to receive a cancer diagnosis at an early stage. So that's why prevention and screening is really important, that we can make treatment more accessible and hopefully help people live with and beyond cancer diagnosis. But we know that there are multiple barriers in firstly deciding to take part in cancer screening and then access cancer screening programs if people want to, but then also engage in prevention behaviours, so such as reducing smoking, reducing alcohol consumption, engaging in physical activity, having the HPV vaccination. All of that forms under cancer prevention. But to date, and as we've all had lots of presentations already over the past few days, lots of people are doing reviews already on similar topics, so whether that be screening only or prevention only. So we really needed to bring all of that learning together and not just replicate what's already being done, but bring that learning together so we can identify what needs to be done across screening and prevention. So that is why we decided to do a systematic review of reviews. So we're looking at researchers, what they've done already, to then bring all that learning together. So, like I've said, the aim is to hopefully identify ways that can help people with an intellectual disability prevent cancer and be screened for cancer if they want to have cancer screening. So our three main objectives was to identify the barriers and facilitators relating to cancer prevention. Second one is cancer screening. And then the third objective is to identify research gaps and recommendations from what other researchers have done. So we can then bring all of that together and feed that into our research agenda as part of Working Group 3 deliverables, so we can then say this is what researchers need to do moving forward to progress the field. So like I said, we have used a systematic review with reviews, so we're only looking for systematic reviews. Any other type of review we've excluded because we know that systematic reviews are seen as that highest quality of data that exists. We've searched for 9 academic databases. We've done reference list searching, so that's what forward and backward searching means. We've looked at the references to see if we've missed anything. And we've done that a few times, going backwards and forwards, so that a lot of work has gone into that forward and backward citation. And what we're really interested in is the barriers, so what stops people, the facilitators, what can help people, thinking about accessibility, knowledge, what motivates people into just going to screening or prevention, and then specifically what interventions might exist or have been tested to kind of help people make them decisions and go. Now, we are using the social ecological model, so for those that don't know about the SEM model, it it looks a little bit like an onion. So in terms of there's a central layer and then the layers build outwards. And at the centre of that model is the individual. So the person with an intellectual disability. What do they think? What do they know? That then builds out to the family, carers, friends, building out to the community level. So that might be your intellectual disability nurses, your community, your screening staff. And then that leaves the outer level, which is the policy. Okay, so what policy exists, or as we found, doesn't exist on cancer screening and prevention for this population. And the QR code on the screen will take you to our protocol, which goes into a lot more detail about the methods that we've used. So this is our very preliminary findings, okay? So emphasis on preliminary. So this is still ongoing, but really interesting results. So we've had 20 included systematic reviews, okay, to date. 14 focus on screening specifically. So the majority of them look at cervical, breast, and bowel screening. Only three focus on prevention activities only. And there are 4 that focus on both. So there's a mixture. So it might have looked at screening and physical activity or vaccination, you know, so it's combining both of them things in the one systematic review. The reviews were published from 2016 to 2026, with the majority being in the last kind of 10 years. Okay, so again, thinking about the Cupid network, a lot of that research is current and up to date. Okay, which is good. It shows that there's other people doing this research. The primary studies represent a diverse geography, okay, but the majority of the papers are from Europe and North America, okay, with the UK and the USA having most of that representation. And what the kind of model on the screen shows you, so this is what the social ecological model looks like, okay? And the bubbles alongside are kind of a summary of what the barriers and facilitators are for each of them levels. So what we've found at the individual level is that fear, distress, embarrassment, and feeling of being unprepared affect screening and prevention. So this has brought all the data together. What we kind of undecided at the minute is we might separate them out and just do one of these models for screening and one of them for prevention, but we are undecided yet given the small numbers of the prevention studies only. We might keep it as a combined. At an interpersonal level, carers and family members are unaware about screening. They might have unfavourable opinions around screening. You know, we heard yesterday about people perceiving sexual activity, meaning someone might not need cervical screening. We know that's kind of an unjustified perspective to have. So that is some of the barriers where facilitators can be, as we've heard this morning, about carers and support attending appointments and accompanying people to screening specifically. At the organisational level, having protocols and screening systems specifically for people with an intellectual disability, which we know doesn't happen or doesn't exist as standard across different countries. And that can really help people have flexible appointments, have embedding reasonable adjustments within the systems, can really help people make informed decisions and then access screening and prevention activities if they want to. Moving outwards to the community, awareness campaigns, you know, making people aware what screening programs exist, what they are, to demystify some of these preconceived ideas at a much bigger level. So you're hitting people with an intellectual disability and also family paid carers as well. And then lastly, at the policy level, basically there are no inclusive screening policies for people with an intellectual disability, and that's what the research is highlighting as well, which supports what we found in Working Group 2's work, that it just doesn't exist. So again, how we can then embed reasonable adjustment within systems is going to be an issue because there isn't the policy that drives that initiative across screening and prevention initiatives. So what does this mean? Our initial implications is that there is a need for personalised approaches. We heard this morning from our wonderful presenters that there's a need for personalised care here, and that just isn't happening for people with an intellectual disability. It's a one-size-fits-all system which doesn't allow for bend or flexibility based on people's needs. And I'm advocating that needs to be in place. Reasonable adjustments need to be identified before someone is eligible for screening, before they're being invited for HPV vaccinations, so things can be put in place to make it easier for them to have and make informed decisions. There needs to be a whole system approach, so factoring in all of these layers, okay? We need to not focus on just one level So not just do things at an individual level or not just do things at an organisational level. We need to bring all of that together to look at that whole picture, which is hopefully what we'll do by doing this systematic review. Now, most of that literature, as I've said, focused on cancer screening, okay? So we know there are silences in the research that's being conducted, which means there will be gaps in the review, which is inevitable and potentially a limitation. But again, we can feed that into the research agenda to say these are silences in the data, so there's your research studies topics moving forward. So, for example, there's a silence around sun safety and sunscreen use in the published data. Now, we have to be careful because we have excluded scoping reviews, so it might be that they are out there, but they're not systematic reviews on sun safety for people with an intellectual disability. Okay, so we will use all of this data and bring that into the research agenda moving forward. So to conclude, we've identified multiple barriers and facilitators that can help people access and engage with cancer prevention and screening programmes, but there needs to be this whole systems approach and look at whose responsibility is it around cancer screening and prevention. It's not just the family carers, it's not just the healthcare professionals, it's not just the policymakers, it's everyone's responsibility to have this on their agenda and think about screening and prevention as an equal way of tackling cancer and making it more accessible for people to get a cancer diagnosis earlier. And lastly, just to reiterate what Working Group 2 are doing, there needs to be policy changes. Okay, without policy changes, without that being a top-down approach, systems and the people on the ground are not going to benefit from any changes. Okay, so thank you all for listening. And like I said, this is an ongoing project, so I will be in touch for help. Thank you.
Thank you, Kate. Massive work has been done so far, and still a lot is left. So you have us next accompanying you in this challenge. A lot has been done with the papers. A lot has been done so far, as you could hear from our presenters, and a lot has been spoken about the burden of parents, people who are very close on a daily basis to people with intellectual disabilities. So now let's listen to this part of work, which will be delivered by Professor Emine. The title of the presentation is The Effect of Caregiving Burden of Parents of Children with Special Needs on Their Levels of Cancer Screening Behaviors.
Hi, everyone. I am Professor Emine. I am come from Turkey. I am working Akdeniz University Nursing Faculty, Child Health Nursing Department.
I think I will need your help. The cursor doesn't want to show.
Thank you very much for inviting to me the final conference organization committee. The effect of caregiving burden of parents of children with special needs on their levels of cancer screening behaviors, a regression analysis study. Caring for children with special needs imposes a significant emotional, psychological, and physical burden on parents. This burden may negatively affect parents' awareness of their own health and their health-related behaviors. The aim of the study was to determine the caregiving burden of parents with children with special needs and to examine the effect of this burden on parents' cancer screening behaviors. The study included parents of children aged 0 to 18 years attending special education schools affiliated with the Ministry of National Education in Turkey. Data were collected using the Parent Descriptive Information Form, the Attitude Scale Towards Cancer Screening short form, and the Zarit Burden Interview short form. The result of this one, most participants were female and the majority had no cancer diagnosis, and a significant moderate negative correlation was found between Zarit burden and cancer screening scores. The linear regression model was significant, indicating that higher caregiver burden sufficiently predicted lower cancer screening attitudes. This finding highlights the importance of considering caregiver burden in nursing interventions aimed at improving attitudes toward cancer screening. Increasing caregiver burden was associated with lower attitudes toward cancer screening, suggesting that individuals with higher caregiving burden may be less likely to participate in cancer screening behaviors. These findings emphasize the importance of nursing interventions that addresses caregiver burden to improve participation in cancer screening. This is my reference. Thank you.
Thank you very much. Excellent speed. Martin is happy. 3.5 minutes. 2.5? 2.5 minutes. Oh, perfect. Nice. Okay, so nothing could be done without interventions. So now let's listen about interventions, the review of randomized studies. Miss Irem, Huri, Karabiyik, apologies, because I'm sure I'm not pronouncing it correctly. But the floor is yours, please.
This one, lovely, perfect. Perfect. No problem.
Hello everyone, I am Irem. Today I will present our systematic reviews, effect of intervention to increase cancer screening and prevention among individuals with intellectual disabilities, a systematic review of randomized controlled trials. We conducted this study with my supervisor Ayşegül. I would like to thank her. People with intellectual disabilities do not fully benefit from cancer screening and prevention programs. Also, they may face barriers such as communication difficulties, limited accessible information, dependence on careers, and difficulties in using health services. Because of these barriers, cancer may be diagnosed later in this population. So the aim of this review was to explore the effectiveness of intervention designed to improve cancer screening and cancer prevention among individuals with intellectual disabilities. And we focused on two questions: which intervention were used and what effects did these interventions have? In method section, this study designed a systematic review of randomized control trials. There was no time restriction in the search process. We searched PubMed, Scopus, Web of Science, Cochrane, Senay and Medline database. Also, we searched Gray literature sources. And we defined inclusion criteria according to the PICOS criteria. For population, individuals with intellectual disabilities, we included also learning disabilities, developmental disabilities, Down syndrome, and mental handicap. And for intervention, we focused on cancer screening or cancer prevention interventions. All cancer types were included in this review, such as colorectal, breast, cervical, and also testicular cancer. We included. Cancer prevention behaviors structured according to World Health Organization recommendations. These recommendations included such as physical activity, exercise, healthy diet, smoking or tobacco use, also drug addiction. Control group, standard control protocol, and study design, randomized control trials. For each study, we extracted data extraction table. We can see the criteria for table. This is my study selection process. Study selection followed the PRISMA framework. In total, 71 randomized control trials were included in this review. The main reasons for exclusion criteria in here. For exclusion criteria were that some studies were not specific to cancer, some were not specific to intellectual disabilities, and some did not meet other reasons. In results, we included 71 randomized control trials, and these trials focus on 68 study cancer prevention and only 4 study focus cancer screening studies. First, included studies covered years 2007 to 2026. The evidence increased especially in recent years, with many studies published after 2021. The studies came from many countries. The most frequent countries: USA, Australia, China, United Kingdom. Sample included children, adolescents, adults, and older adults. Population age ranges from 7 to 9 years. Many studies included individuals with mild or moderate intellectual disability. In terms of intervention, most evidence was about lifestyle-related cancer prevention. Physical activity or exercise appeared most often. So the main results here is that evidence was clustered around physical activity, healthy diet, and weight management. In the second step is how the interventions were delivered. Many interventions use accessible or educational materials. These materials included easy-read booklets, visual materials, videos, games, or practical demonstrations. Also, technology supported intervention common. These included mHealth tools, online platforms, Zoom session, virtual reality tools, Fitbits, or mobile apps. Family and career support was also important or study. Some studies involved parents, mothers, carers, paid assistants, teachers, nurses, and support staff Some interventions were delivered in school, group homes, community settings, and care settings. The outcome pattern was mixed but generally positive. Lifestyle outcomes were generally beneficial, especially for physical activity and diet. In conclusion, this intervention improves the cancer prevention and screening behaviors. Especially lifestyle intervention supported cancer prevention. So, future programs should be simple, accessible, and supported by families, careers, and professionals. Thank you so much for your attention. I'm so excited. This is my affiliation. Okay.
Thank you very much for sharing it. Please keep your questions. We will have one last presentation and then a few moments for asking the questions. So if you have any, we'll have the opportunity to ask them. All we do in Cupid is for people, and it wouldn't be possible without real life stories. So the last presentation of the session will be devoted to the real life story. It will be presented by Dr. Natalie Gill. Please welcome and take the floor. Natalie is going to speak about experiences of the cancer care pathway for adults with intellectual disabilities and their supporters. Do you need some help?
Thank you. Yeah, I don't know where.
Okay. Let me just...
Okay, great. Thank you. Thanks. Okay. Hi, everyone. It's great to be here with you all after 4 years of relationship building and advancing our shared goal of improving equitable care for people with intellectual disability. So we've talked a lot about cancer prevention and equitable access to screening for people with intellectual disability. But today I'm going to present a piece of research from my PhD which looked beyond early detection and focused on understanding the lived experiences of the symptomatic diagnostic pathway for people with intellectual disability and their supporters. I have spoken to some of you before about this project while it was ongoing around the inclusive methods that I used. And today will be more of a focus on the analysis and the findings from the work. So as we know, people with intellectual disability experience substantial inequalities across the cancer pathway. These inequalities extend beyond prevention and screening and into the diagnosis of symptomatic cancer. And this is important because screening only detects a minority of cancers. And even in countries with established screening programs, most cancers are diagnosed after a person develops symptoms and presents to healthcare services. And furthermore, national screening programs only exist for a number of cancer types. And we know from previous research that people with intellectual disability are more likely to be diagnosed through emergency presentation, which is often associated with poorer outcomes. However, despite this, we know remarkably little about how people with intellectual disability navigate the pathway from first symptom to cancer diagnosis. And much of the literature has focused on screening uptake, while the experiences of symptomatic help-seeking, referral, and diagnostic investigation remain largely unexplored. Therefore, the aim of this study was to understand how people with intellectual disability and their supporters experience the pathway to symptomatic cancer diagnosis and to identify where inequalities may arise. And I've used the term supporters here as the people who were interviewed had various supportive roles in the lives of people with intellectual disability. And this was from formal and informal care roles to professional advocates working in the third sector and intellectual disability healthcare professionals. The interviews were conducted over a one-year period, and the data was then analysed inductively using reflexive thematic analysis, followed by an abductive theory-informed phase of analysis where the themes that were generated were considered in relation to candidacy theory, which considers how access to care is negotiated between patients, clinicians and systems, and the health stigma and discrimination framework, which provides a lens to analyse how stigma is generated and reinforced across individual, interpersonal and structural levels and influences whose symptoms and concerns and treatment experiences become recognised and legitimised and acted upon within services. So I'll just give a little bit of detail about the analysis approach. As anyone who's done qualitative analysis will know, it's not as simple as dealing with numbers where a definitive answer exists. It's lengthy and interpretive, but when done well, it should be a meaningful and deep reflection of a shared understanding that is built between researcher and participants. So I began inductively and stayed close to the participants' experiences rather than using any pre-existing theories at that time. And I analysed the learning disability and advocate transcripts separately to preserve the integrity of each perspective before I brought them together into an integrated thematic framework. And following this was the abductive phase of analysis, where I drew on the candidacy and health stigma and discrimination framework as sensitising concepts to help to interpret and explain the patterns that we were seeing in the data. And this is important because it allowed the findings to remain grounded in participants' experiences, but also provided a theoretical lens for understanding how inequities emerged across the pathway. So jumping into the findings, so for people with intellectual disability, participants described accessing healthcare as a continuous struggle to be recognised as a legitimate candidate for care. And what we saw was that inequity, it wasn't just about unequal access at the beginning point, but rather it was a continual process that was produced through everyday interactions within clinical encounters, from their concerns not being recognised or taken seriously until the point of crisis, to diagnostic overshadowing whereby symptoms were attributed to existing conditions or to the intellectual disability itself, and also the assumptions that were being made about cancer risk, lifestyle, tolerance for procedures or treatments, the capacity to consent or participate in their own healthcare. Alongside this were inflexible pathways that were unable to adapt to the care needs of people with intellectual disability. And this led to situations where progression through care became dependent on the availability and capability of advocacy, which is, of course, an informal support structure that is unevenly available. And this is a concept that extends our existing understanding of candidacy into a concept that I termed advocated candidacy. But it wasn't all bad news. There were examples of good practice and compassionate care. And what participants described to me as helpful was this compassionate, flexible approach to care where their concerns were taken seriously. They were given enough time to express those concerns. There was additional time in appointments. Clinicians used adapted communication methods and involved supporters appropriately. And also where care was well coordinated across the pathway and different sectors. So what this points to is that there is often a mismatch between what care pathways expect and what a patient with intellectual disability needs to be able to access effective care. So, for example, it may expect fast articulation, clear verbal communication, independence, whereas people with intellectual disability need flexible care pathways, monitoring and use of reasonable adjustments, and anticipated coordinated support across health and social care systems. So several concepts were developed from the findings, and one I'll just touch on today is what I termed the myth of the normative patient, which describes the assumptions that are embedded within care pathways about who patients are and what they can do. And care pathways often appear to be neutral, but they implicitly assume a patient who can recognise symptoms, seek help, communicate concerns, and navigate services. And advocate for themselves. And people with intellectual disability are often disadvantaged, not because of impairment, but because the pathways are designed around these assumptions. So the problem is not the patient, it is the fit between the patient and the pathway. So what are the implications? What does this mean in practice? Well, first, we need to move beyond the normative patient to think about how we can design systems that don't assume independence, health literacy, or confidence, but instead that anticipate cognitive and relational diversity. And secondly, accessibility needs to be embedded throughout pathways rather than added afterwards. So in developing and providing accessible information, anticipating support needs, and routinely recording and implementing reasonable adjustments across fragmented services. We need to reduce reliance on exceptional advocacy by strengthening formal support structures. And finally, we need to address inequity upstream, not only at the point of diagnosis and treatment, but also through improved awareness, recognition, healthcare practitioner training to support the legitimacy of concerns and timely access to investigation. And importantly, the concepts that have been developed from this work, such as advocated candidacy and the myth of the normative patient, have broader applicability beyond intellectual disability. For example, people with physical disabilities, severe mental illness, dementia, neurodivergence, all of whom will face specific barriers to accessing and moving through care pathways that are not designed with them in mind. And so moving forward, if we design flexible pathways that anticipate patient diversity, then we're likely to design better systems for everyone. So thank you to my participants, my PPIE and my supervisors, and thank you to all of you for providing a supportive community of practice throughout this PhD journey.
Thank you very much. That was very inspiring. We have a few moments for questions. Would anyone like to ask a question? Or, yes?
Mine is just a comment, and it's to Kate. Where's Kate?
She's back there.
Do you dread me? No, Kate, it's just a compliment, really, on an excellent presentation. And in many ways, I suppose I'm not familiar with ecological systems theory being applied to a systematic review in terms of extrapolating the challenges or opportunities in terms of that meta-synthesis. Mm-hmm. Yeah.
It's really quite complicated because I think we've all identified the barriers and facilitators, like through Barry's session with Martin and Vladimir yesterday. We know that's what the barriers are, but it's about kind of who is going to take that ownership, what do we need to do specifically at each level. Yeah. So I think it goes beyond just identifying what them barriers and facilitators are, because it gives you that roadmap to say, right, okay, this is what we need at this point, this is what we need at this point. So then in terms of, you know, roles and responsibilities, who can do what, it clearly provides that mapping to say, right, you need to work together, these systems need to talk, you know, so it does provide that clear message. So yeah, thanks, Maggie.